Annette Quinn. Annette is the program manager of radiation oncology at the University of Pittsburgh Cancer Center. She is instrumental in implementing the first PBM oncology clinic in her practice for oncology patients at risk for oral mucositis. Annette, thank you for your participation, and we look forward to hearing some interesting information here.
Hello, everyone. Thank you for having me. Let me just share the screen here. Hold on. Okay. I hope everyone's having a good evening. Thank you so much to Thor for sponsoring and for ALD for having me to speak. I am so excited. I have been an oncology nurse for 30 years and have a lot of experience. One of my greatest passions is in oral mucositis. I have been around a long time and have seen a lot of therapies come and go. One of the most exciting things that ever happened to me was the development of a PBM clinic in our radiation oncology department. It really has changed how we practice. It really has, and I always get emotional when I give these lectures. It has really changed the quality of life for my patients, and that is what is so incredibly exciting. I have no commercial relationships. I am a very hardworking advanced practice nurse. I am in the trenches. I am working with these patients every day, seeing them suffer through some very debilitating side effects of cancer therapy and just really wanting to have that magic wand to make it better. And I always say that I finally do have it when it comes to oral mucositis. So I'm excited to talk to you guys and share some of my experience, some of my knowledge. James touched a lot on the oncology practice. We do use it in a couple different realms in my world, but I'm really going to focus on oral mucositis because that's where we have seen such tremendous benefit. So we all know what oral mucositis looks like. These are just some pictures of OM. It can be very confluent and it can coat the whole mouth, the lips, the soft palate, the buccal mucosa, go all the way back and coat the uvula. It can be very isolated, as we're seeing in the new targeted therapies, that these patients really develop simple aphthous ulcers, but they can grow to be very large, about the size of a $50. In our radiation patients, it's really where, you know, the beams are at their greatest. If we have patients that have metal fillings, we will see the OM sort of really be really around that area and very confluent right in that area. So we tend to really look at those patients and prophylactically treat that. We know what oral mucositis is. It's a common complication among cancer patients. It affects the buccal mucosa, the soft palate, the tonsillar pillars, lateral tongue. It goes all the way down through the esophagus. Patients that are getting stem cell transplant, it goes all the way down through to the anus. These patients will get very bad gastric mucositis from their stem cell transplant conditioning regimens. It's progressive. It's incredibly, incredibly painful. It impairs eating, swallowing, speech, and most important, quality of life. There's a lot of risk factors that we see when it comes to OM. Obviously, patients that are neutropenic in my world with a, you know, extremely low white count. These patients, when they are neutropenic, especially our stem cell transplant patients, where we completely wipe out their white cells, they are at zero. If they develop oral mucositis, it puts them at extremely high risk for infection and sepsis. I have seen over my career, probably, you know, 20, 30 patients who develop OM who end up dying from sepsis from their stem cell transplant therapy. So it can be very common. Poor oral hygiene, impaired salivary function, obviously the use of alcohol and tobacco. We know for a fact that radiation therapy at certain doses to certain areas and certain chemotherapy regimens. And now in the world of immunotherapy or targeted therapy, we also see an increase in OM. Concomitant medications, patients that are on certain medications can be at higher risk for OM. The type of regimen that they're getting, is it high dose chemotherapy? You know, are they getting it together with the radiation? Specific chemos, genetic factors, children and elderly, and obviously anybody that has poor nutrition, which is most of my head and neck cancer patients are at very high risk for the development of oral mucositis. Progression of OM, and I always like to put this slide in here because people always think that OM starts when we see the eruption of the ulcers, and it's so not true. And this is where you see a lot of therapies fail. And once we get to the eruption of the ulcers, the pain is so incredibly bad and so difficult to control that we really need to be starting on their first chemotherapy dose and their very first day of radiation. And that is currently what we do in our PBM practice, is that, you know, we start on their first day. And these patients, some patients, especially if they've been getting chemotherapy, we will start a week before they start their radiation. So it really begins in a phase 1 where you get their first dose of radiation. There's already epithelial changes going on. You know, you're seeing a lot of cytokine reaction. You're seeing a lot of inflammation. And it keeps progressing. There's a lot of downward cascade where you have messaging and signaling and increased cytokines. And then you develop the ulceration, and the ulceration really is the last phase of oral mucositis. But this is where patients, especially stem cell transplant patients, or oncology patients with a very low white count, could be at very high risk for infection and sepsis. And then phase 5, which is healing, which is when the body decides it's best. The other thing you have to realize is some of these patients have had chemotherapy in the past or have had conditioning regimens before transplant in the past. And so their healing takes a lot longer than a normal patient would take because they've been through it before. So we know that, you know, if you've had OM in the past, then you usually have a rougher course the second time around. Factors that affect the duration of OM, we know what type of chemotherapy. Not every chemotherapy is going to cause oral mucositis. Not every type of radiation is going to cause oral mucositis, even to the head and neck. If we're doing very pinpoint radiation, we really should be able to spare a lot of the areas that are at high risk for oral mucositis. Total body irradiation, which we use in our pre-stem cell transplant patients, put a patient at very high risk for OM. Radiation therapy to the head and neck, we typically say 100% of patients will develop some type of oral mucositis. Decreased neutrophil count, individual factors, genetic predisposition, age, tobacco, alcohol, we talked about that, and then any superimposed mucosal infection. I always like to talk about the difference between OM and radiation and OM and chemotherapy because it is a completely different course. In the chemotherapy world, patients, I always say, will develop OM on the movable mucosa. Typically, you see it on the cheeks, you see it on the tongue, you see it on the lips. In radiation therapy, we see it everywhere. These patients will develop it on the hard palate, back on the soft palate. So you tend to see more areas when you're receiving radiation than you see in the chemotherapy world. Typically, the chemotherapy patients, a lot of it is on the sides of the cheeks, the buccomucosa, and really bad on the lips, and then in the back on the soft palate. Radiation, it's usually less acute in onset. Chemotherapy, and I see this constantly, they go to bed at night eating and drinking and no problems, and they wake up in the morning on a PCA pump. That's how quick it can happen in the chemotherapy world and the stem cell transplant world. So as soon as, you know, we examine their mouths in that arena and we see even a little bit of redness, these patients are typically started on a pain pump before we had PBM. Patients begin to develop mucosal sores about the end of week 1 in radiation. So we always tell patients, you know, the first week you'll do okay. By the end of the first week, you'll start to feel a little soreness in your mouth. And we tell them by treatment 12 or 13, you're going to hate us. You're going to be pretty miserable. You're not going to be able to swallow. You're going to have, you know, painful lesions. And the intensity increases in radiation until you see a lot of ulcers around week 2 or 3, and it continues to progress. And the interesting thing about radiation is it doesn't stop when we stop. I mean, these patients typically about a month out are still experiencing some significant oral mucositis. It typically develops around closer to about 30 gray when we're using standard fraction radiation, and concurrent chemo leads to an earlier onset. So it can be seen at 20 gray, and most of our head and neck cancer patients do receive a concurrent chemotherapy consisting of cisplatin, which is also pretty high up there on causing oral mucositis. It consolidates to form confluent mucosal ulcers by the end of week 3, and it can last weeks to months, depending on the intensity of treatment. You know, we do have some patients that come back, they see us in a month, and it could still be pretty bad. Ulcers resolve spontaneously in most instances. You know, there's really nothing magical. We can't tell when, but they do resolve spontaneously. Targeted therapies are very big right now in the oncology world. We got a lot of monoclonal antibodies that we use on these patients, and the toxicities that we see in the oral mucosa with these are very interesting. So they don't develop the confluent oral mucositis. They tend to get really big aphthous ulcers that are incredibly painful. And the unfortunate part is typically they're on the top of the tongue, bottom of the tongue, back on the soft palate, and they're really excruciating to these patients. I always like to tell this story. I had a patient, and his pictures are at the end, but he was 35 years old and he had a renal cell carcinoma, and they put him on a targeted therapy, and he developed, it was the size of, it was big. It was probably the size of a quarter on both sides of his buccal mucosa, and it was just getting larger. And he wanted to quit therapy. He was 35 years old, and he said, I'm done. This is so incredibly painful. It's not worth it. I don't want treatment. And so they had called me to see if I could do anything with the laser, and we treated him, and he did incredibly well. And like I said, I'll show you the pictures of him at the end, but he was 35 years old, and he wanted to quit treatment due to aphthous ulcers. So you can see how incredibly painful these are in patients and how they affect their quality of life. So the broader term stomatitis is preferred to mucositis for describing the mucosal injuries and other oral toxicities. And like I said, they typically resemble aphthous ulcers. So these are patients that you'll probably see in the dental world because, you know, most of these target agents are oral agents, so they're not coming into clinic a lot. These patients are taking them on their own at home, and when they develop an ulcer, they sometimes see their dentist, they're concerned. So you're going to see these patients present in your clinic, and let me tell you, PBM is fantastic in that population. We know that mucositis causes a lot of pain. I talked about infection. You know, one of the biggest things that we see is decreased nutritional intake. You know, my oncology patients need double the calories when they're undergoing treatment. So, you know, decreased nutritional intake is incredibly concerning in our practice. We often have to give these patients feeding tubes. Before we had PBM, you know, these patients were getting feeding tubes placed so we can keep up their nutrition. And, you know, when you have a patient that's going through head and neck cancer treatment and you're already, you know, they're in pain, they're miserable, not being able to eat is very depressing to a lot of patients. I mean, it's incredibly depressing to them. So we really like to try to maintain as much of their normal life as we can because, you know, we need them to get the nutritional intake and we need them to stay positive. But whenever you take away food, I always tell patients undergoing this type of treatment that, you know, eating becomes a job. It's no longer a pleasure, and you're going to have to look at it as a job. And we don't want to do that. We want to try to maintain their life as normal as possible. Another incredibly big thing that mucositis can cause is interrupted cancer treatment, and that can be horrible. You know, there's studies showing that patients that miss 5 days or less have a better overall survival than patients that miss 5 days or more. So the last thing we want to do in the oncology world is interrupt cancer treatment. We don't want to do it, especially radiation therapy. And when patients have to get admitted for oral mucositis and they're, you know, in the hospital on a PCA pump, and we have to hold their treatment because they're in so much pain or they're refusing to come in, or I don't want to do this anymore, it really affects their overall survival. And head and neck cancer is pretty curable. You know, you're looking at really high cure rates if we can get them through treatment. Same thing in the medical oncology world with chemotherapy. We often have to dose reduce patients because of oral mucositis. And you see that a lot in rectal cancer patients who get a drug called 5-FU. They often have to dose reduce it due to OM. So any way we can prevent it is obviously, you know, a benefit to the patient and their overall survival. And it causes a lot of fatigue. Why? They're not eating, they're not drinking, they're taking pain meds. It really wears them down and they develop sort of a failure to thrive. There's a lot of impact of oral mucositis, and financially, mentally, and with our treatment. So what we did in the past is we gave them opioids, and it was really our first choice. These patients would start to develop, OM. They would say that their mouth was sore, and we immediately started pain medications. And I told you, in the inpatient stem cell transplant unit, these patients immediately were put on controlled analgesia of Dilaudid, because we know how bad it gets and we need to get them through treatment. We basically knock them out so that they're in pain, which is not what we want to do, but was our only way of handling it in the past. They often end up on antibiotics, additional clinic visits, hospital admissions, increased hospitalization. Mostly about 85 to 90% of our patients needed feeding tubes, and obviously quality of life issues. So one of the big things that when we developed our PBM program at UPMC, and when I go out to other centers and they say, well, my hospital doesn't want to buy a laser because it's expensive, and we don't have this in our capital budget. I always say, well, here's the economic impact of oral mucositis. So you're looking at about an increase of $1,700 to $6,000 per patient. And you're looking at additional hospital costs can be as high as $25,000 per patient. And in 2009, Medicare reimbursed over $40,000 per patient with ulcerative mucositis lesions. So, really PBM is very cost effective. So you're looking at a lot of increases in patient hospitalization and increase in hospital costs if a patient develops oral mucositis. We use in our practice, we use what's called the Oral Mucositis Daily Questionnaire. So, I'll talk a little bit about our study coming up. We have treated, we really don't even keep count anymore because I have so many units in the hospital, but I would say we're probably well over 2,000 patients that we've treated with oral mucositis at the University of Pittsburgh. We started the program late 2016, so early 2017. We now have 3 units on our stem cell transplant. We have 1 in our outpatient oncology unit. We have 1 in radiation therapy. We have other centers, community centers that have them, which, I don't even factor in their numbers when we're looking at that. So, we've treated a lot of patients, and when we did our study, I'll show you, we looked at 50 patients, because when we started this program, we were skeptical. I mean, you heard James's talk. It's like PBM, cures what ails you. And I'll never forget, James, I had read about PBM, and then we had a patient that he was elderly. He was about 72 years old, and he was getting head and neck cancer treatment with combined chemotherapy. And he was on treatment 22, and he had absolutely no oral mucositis. And my doc and I looked at each other and we were like, what the heck is going on? So we asked him, we're like, what are you doing? Because this is incredibly, incredibly rare. And he said, oh, my daughter's a dentist, and she shines this magic red light in my mouth, every day. And we're like, oh. So we started looking into it. But when we got the unit, we were still very skeptical of how well it would work. And, we sort of thought, a little witchcrafty. It seems to, to fix everything. And we treated our first patient, and he made it all the way through with absolutely no oral mucositis. And my doc and I looked at each other and we were like, oh my gosh, like this is incredible. And so we started treating everybody. And then the doctors on the floor heard what we were doing. And, we had patients that, would be in for their chemotherapy, and they would be requesting their red light therapy. And all of a sudden the whole hospital knew about this treatment. And we just started rolling up our sleeves. And I was treating from 8 o'clock in the morning till 10 o'clock at night, because it was working so well that ethically, if they called me at 9 o'clock at night and said, this patient's in pain, I did them, because I felt that, ethically I could not share this wonderful treatment with them. So we did a lot of patients. And then when we sat back and looked at the data, it just wasn't clean. It wasn't neat. We didn't, we had residents grading our oral mucositis. We weren't using a consistent questionnaire. We were using the WHO quality of life questionnaire, which really looks at overall quality of life. And so a lot of these patients, we were helping their oral mucositis, but they were still developing esophagitis. They were still losing weight because it was interesting. Patients would not eat who were getting head and neck cancer treatment because they said it was too painful. Now that we were fixing the OM, they weren't eating because nothing tasted good. So they just had no desire to eat. So it was funny how the dynamics had changed. So we had all these patients and we had, all these good success stories, but we couldn't pull together really good, solid data to publish a paper. So we said, forget it. We're going to start today and we're going to look at, a small cohort of patients that are getting a certain dose of radiation with cisplatin chemotherapy. And we're going to really have some really good quality of life, questionnaires and good data. And that's what we did. So we used the oral mucositis daily questionnaire because it really focuses just on the oral cavity, which is what we're treating. We're not doing anything for the esophagus. We're really just treating the oral cavity. So that's why we stuck with this questionnaire. I always like to go through these because this is what happened in my practice. This is oral mucositis. You guys know that. But I would have residents grade this as grade 4 OM, which is thrush. So, we do a lot of training, and before I start the PBM program, before any nurse comes on board, they go through a very thorough how to do a good head and neck exam and examine the oral cavity. And I teach them that this is not grade 4 OM. This is thrush, and an easy way is wet a Q-tip and rub it on the back of their throat. And if it comes off, then it's thrush. But my residents will consistently grade this as OM. These are aphthous ulcers. You guys know that. I love the laser because I get aphthous ulcers all the time from eating chips and salsa, so I love it. Good story is I have a patient who had an aphthous ulcer from targeted therapy on the center of his tongue, and it was the size of a $50. It was so painful to look at. And he would come in every day and I would laser him and I would say, oh my God, I feel so bad. And I'd talk to him, what'd you have for dinner last night? Oh, I had hot sausage. I had pizza. And James touched on this. The interesting thing about PBM is that you may still see ulcers and they still may be pretty big, but it has an analgesia effect that is tremendous in these patients. So, sometimes we still see patients with very confluent oral mucositis and we still see it develop, but they don't have a quarter of the pain of other patients. So I even notice on myself when I get aphthous ulcers and I use PBM that I can still eat tacos. I can still eat my chips and salsa. It's not as painful. So it does have this analgesia effect. This is typically what our patients' aphthous ulcers look like and where they are. They're usually back on the soft palate. And like I said, they're tough. Patients, especially when they get them on their tongue. This is herpes simplex. We have used it on patients. The stem cell transplant docs will call me and say, hey, I have this patient, their white count is 0. They're starting to get some, herpes simplex lesions. And we have seen them not have as much of a significant outbreak with herpes simplex. So it has worked in those patients as well, but that's common to see in our stem cell transplant patients. So update on the PBM guidelines. What's really neat is that there are very good governing bodies in the world of oncology that support photobiomodulation. This is our practice. This is the practice of supportive care in oncology. And this is 250 experts from 33 countries. And they are recommending the use of intraoral PBM therapy using obviously LLLT for the prevention of OM. Now, I will tell you that to this day, there has never been mention of anything out there that can help to prevent oral mucositis. I have sat on a lot of advisory boards for big pharmaceutical companies. I have been through probably in my 30-year career being an OM expert in the oncology arena, pipelines of so many drugs that have come out and oral mouth rinse agents, Mugard and things like that people just thought would be very beneficial in patients, and it's not. and none of them were preventative. So, you know, the mucosal coating agents, Gelclair tend to help a little, but nothing was preventative. So, you know, for the panel to recommend, you know, 250 experts to say for the prevention of OM is very big. And it's in adult patients receiving stem cell conditioning regimens or with or without TBI. And it also recommends the use of intraoral PBM therapy using LLLT for the prevention of OM in adults receiving radiation to the head and neck, with or without actually chemotherapy. And finally, I don't know if I did double that, but it is actually with or without chemotherapy currently. The Cochrane review analyzed the prospective data assessing the management of oral mucositis, and this was 32 prospective trials, including 1,500 patients. 3 comparisons for mucositis treatment, including 2 or more trials, were assessed. And interesting, only LLLT or PBM showed a reduction in severe mucositis when compared to the sham procedure. So here's our experience, and like I said, we did a phase 2 prospective trial, and this was the first one in the US, looking at PBM and limiting OM in the treatment of locally advanced head and neck cancer with patients receiving cisplatin chemotherapy. 47 patients were analyzed when the trial was over. PBM was delivered 3 times a week. So we start on day 1 of their radiation therapy and throughout their course of radiation therapy. Primary outcomes were measured. We looked at the incidence of severe oral mucositis versus historical controls, and secondary outcome measure was time to onset of OM. So severe oral mucositis, like James said, and we looked at only grade equal to or greater than 3, was observed in 11 out of 47 patients, which was about 23%, which historical controls were 40%. So we cut that in half. The other interesting thing was mean time to onset of oral mucositis was 35 plus or minus 12 days, and historical was 15 days. And time to resolution of severe oral mucositis mean was about 37 days. And this is the protocol that we use. You know, Thor makes it so easy for me. So probably Sarah Jane or James would be the best if you have questions about joules and all of that. But I turn it on. It's 2.5 hertz for 1 minute. We use the LED cluster. Now I do have a large cluster. So if you look at the picture down in your left-hand side, I'm able to, with the large cluster, cover that whole area with 1 treatment with my large cluster. So we do here, we do here. We have them stick out their tongue. Now here, this picture shows using the intraoral probes on 4 spots. We coat the whole tongue with a large LED cluster, so the patient sticks out their tongue, and we coat it with the probe, and then we use the intraoral probe on the 2 spots on the back of the soft palate. We do that for 1 minute to each site, and we do it 3 times a week. Now, we do it immediately following radiation therapy in these patients. Maybe more ideal to do it immediately before the radiation, which has been shown that works. Some of the work that Montefiore in the Bronx was doing said that maybe doing it right before the radiation. Logistically, in any radiation center, that does not work incredibly well, because the last thing you want to do is hold up a patient's treatment. The therapists tend to get very angry with us with that. Now, you know, we're doing this prophylactically. So if I'm treating a patient and they develop a lesion, you know, underneath their tongue or, you know, further back on the uvula, we go ahead and we spot treat that. I know certain chemotherapies, 5-FU, like I said, they'll tend to develop it underneath their tongue. So, you know, I know that, so I will prophylactically treat that. Our stem cell transplant patients tend to get it on the inside of their lips. We will prophylactically treat that. So this isn't set in stone. You know, typically for head and neck cancer patients receiving cisplatin, this is perfect. But other patients, you know, you tend to learn, you know, where they tend to get it due to the chemotherapy. If patients have metal fillings, I will prophylactically treat around the metal filling area so they don't get any OM in that area. It has really been a tremendous godsend to our practice. I could tell you, I can tell you a million stories. We got our first unit, we got it through a grant. our second unit, and I always love telling this story, we had a doctorate prepared nurse who was the head of the quality and safety for our hospital, Barb, amazing woman who developed acute myelogenous leukemia. And I will never forget this day all of my life, but it was a Thursday at 3 o'clock, and I got a call from our CEO of our hospital. He had heard about the therapy, and Barb was admitted with very bad mucositis, and she had lost 45 pounds, and they had to put her on opioid analgesia. And she was getting out of bed one day, and she went to unplug her IV pump, and she fell and hit her head. And he said, I understand you have this therapy. Can you treat her? And I'll never forget, I looked at my doctor and I said, okay, if this is witchcraft, she's going to tell me. I mean, she's PhD prepared nurse. She's the head of our quality and safety for the hospital, incredibly intelligent woman. So I treated her Thursday. She had horrible mucositis. I treated her Thursday. I treated her Friday. I came in on the weekend and I treated her Saturday. And when I came in on Monday, her husband was bringing her pizza from her favorite restaurant. So Barb was so instrumental in our whole program. And I always say that I may have started it, but she spread it. So she wrote a grant and we got 2 more units for our hospital. The other units that we have received from our hospital have all come from patients donating money for the machines, patients that have had incredibly good experience. We have been on the local news. We have been in magazine articles for the hospital, and my foundation, who gave us the grant for the very first unit, said it was the best money they have ever spent in their 150 years of the Shady Side Foundation. So it makes me incredibly proud of what a difference this has made in my patient population. James did talk about graft versus host disease. We do see this, especially in our stem cell transplant population. We do treat it. Basically, we treat the entire tongue and anywhere where they're having pain or issues. I've probably treated, my stem cell unit has their own units now, so I don't see many of these patients anymore. I'm just really in radiation. But when I started off, I probably did about 10 of these patients. And I would say, about 8 of them had really, really good results. I have had some burning mouth patients as well who have had a good experience. So kind of neat stuff. My favorite story, I'm so full of stories. My favorite story is I had a patient whose daughter, he turned 70. So his daughter took him to Iceland to celebrate his 70th birthday, and he fell in a hot spring and he was burned from the neck down. And he was in the hospital in Iceland for a little over 90 days. And he came back to the United States, and he couldn't sit. He was so burned on both of his buttocks, his back. I mean, horrible pain, couldn't sit. So he was seeing dermatology. They were doing some 5-FU injections to try to help ease the pain. They sent him to us actually for radiation therapy to try to deaden some nerves. And my chairman of my department said, why don't we try to laser him? And I was like, oh, heck yeah. And so we did. We lasered him every day, and it was time consuming. I mean, I only have, the LED cluster, and I was covering, both, actually Derm did one side of his butt cheeks and we did the other just to do a comparison. But after about a month, dermatology said, look, you're helping him way more than I am. And then we treated some areas down his spine to get the nerve roots. So we did it for every day for 2 months straight. And after that, he sat on an airplane to California to go visit his daughter. So he's one of my biggest fans. We really, really helped that guy. So really nothing to do with dentistry, but just a really cool story of how well it does cure everything that ails you. Okay, so I'll cry over this photo. I really will. This is my patient, and this is so horrible. So she is a wonderful, wonderful person. And she had a neck cancer. Actually, it did invade part of her lip, and we were treating her every day. And you could see the tears. And every day she came in like this. And unfortunately, when someone has active disease in that area, we really try to stay away from PBM because they're looking at the data, and it doesn't look like it causes any progression, but still. We try to be careful. But she was in so much pain. and she couldn't eat, and she came in every day crying, and she wanted to quit. So we did start lasering her, and we lasered her lip, her whole lip, and we did that. And after 3 treatments, this is what she looked like, and we were so happy, and she was so happy. And after a week, this is what she looked like. So if this picture doesn't speak volumes for what PBM does for my oncology patients, I'm not sure what does. But it's just such a good feeling. And those of you in the dentistry world, not every oncology practice has a low-level laser. They don't. A big reason they don't is because of reimbursement. And, we're working on that, and we're seeing more and more insurance companies starting to reimburse PBM because you can see what it does and what we've saved this lady. But they don't. And so often what I do as an oncology nurse, I get calls from people all over the United States now. I have this patient, we're really worried, we don't have a laser. And I say, call your dentist in the area. A lot of dentists have lasers, they can power down. And they can feel free to call me. I'll tell them what we do. I obviously don't know their lasers or their world, but we can help these patients because not every radiation center is going to have the capability to do this. And not every medical oncology center is going to have the capability of doing this. A lot in the chemotherapy world, these patients get chemotherapy and then they go home for 3 weeks and their ulcers develop while they're home. So these are good times for dentists to become effective in helping to treat these patients. This is my patient with the aphthous ulcer that wanted to quit treatment. Yeah, it was awful and ugly and incredibly painful, and we helped him so much. And then this is my boy, Max, who Max and I have become the best of friends. He was a young kid with a gray zone Hodgkin's lymphoma, and he was a tough cookie. He's in fact, if you've seen the video, our TV spot that we did here in Pittsburgh, I used Max. But Max was a tough cookie because, he was all of 23 years old, and he was, a ladies' man, and, he sells houses for a living, and he couldn't talk, and he couldn't eat, and he couldn't go out with his buddies. And this killed him. This was like the worst thing that could happen to him. So we helped Max a lot. Max and I became the best of friends. He's my go-to anytime I need anybody to talk to about the laser. So Max did incredibly well with the treatment. That's all I have. Thank you, guys.
Well, thanks so much, Annette. It's a great service that you're providing for your patients. And we need to spread this information out to others.
Absolutely. Absolutely.
There's been a few questions.
Okay.
So actually, see Carol has a couple questions, and her first question is, how often can you treat, and is there a negative result for treating too often?
So you could treat every day. You absolutely can, but there could be a negative result if you overtreat. That is absolutely true. So when you're trying to heal, if you do overtreat, you can reverse that process. But the best thing to do is to treat daily. We had a gentleman, and he was younger too. He was in his 40s. And this is a great story. He was from about 3 hours away, and he came to treatment at our center because we had PBM. He researched it. He did not want oral mucositis. So he came all the way. He drove every day, 3 hours for treatment to get the laser. And he insisted that we did it every day. We just don't because of time constraints. But you certainly can treat every day in these patients. Sometimes what I'll do is if, I have a patient that develops OM and it's painful, I will treat for healing one day, and then I will treat for analgesia the next day. So if they have a lesion that's very painful, I will use pulsed treatment on Monday, Wednesday, Friday, and Tuesday, Thursday, I will do continuous for an analgesia effect.
Very good. And then she has her second question is, how do you determine the wavelengths to use, since it seems you treat superficially as well as want to experience the benefit from some deeper therapies?
Yes, so James is probably the best to answer that. Like I said, mine is programmed, so it's or Sarah if she's on the line. But if you look at the PBM protocol, and I thought I had it in here, but I don't.
You have it. It's up there.
Do you have it? You know, I've just been doing this for so long that I just pick up the probe and do it. 680 is the intraoral, right? Am I correct?
60.
Up to 980? 660 to 980?
I think it's 660 to 810.
660 to 810. Okay. Yeah, but the Thor has a great treatment library. Here's the funny thing about my center, and it's hilariously funny because we have a room dedicated to PBM. And I always tell people, knock on that door before you go in that room, not because I'm afraid you're going to be exposed to laser, but because I never know who's in there and what they're doing. Like my resident, he'll be in there trying to grow his hair. I have people in there trying to help. They went for a run yesterday and their ankle's sore. My one physicist had his pants pulled down one day because his sciatic was bothering him. I was like, oh my God.
And Nancy Fitzgerald has a question. Have you tried PBM on children? If so, are you using the same laser settings and time?
Yes, yes. Our children's hospital does not have a unit yet, but St. Jude's is using it, and it is the same. It's 1 minute and the exact same wavelengths. And James showed you the lollipop, which is really cool. With COVID, we haven't started using that yet. You can obviously cover it. James didn't, but it can be covered, but we're still just being extra cautious with the lollipop. So you can just stick it in the mouth to cover the hole. So you wouldn't have to do the tongue and then do the soft palate. So that is kind of neat, but I know St. Jude's does have the lollipop, but yes, very beneficial in children. We use it children population, we use it for skin reactions. We have a grant right now with Bristol Myers Squibb. We're doing a study looking at skin reactions in patients, especially with targeted therapies. I had a lady with very large pendulous breast, and my doc's like, she's going to have the worst skin reaction. He's like, let's try to laser her. And we did. And that lady's skin did not break open at all. So that was a tremendous win too. Anything else?
Yeah, Jen Strickler asked, how would you recommend a dentist to go about reaching out to an oncology department to assist with these patients?
Oh, I love it. So I actually have a lot of dentists that pose that question to me. We have a dietitian in our department, and I would much rather have a dentist in my department. I think nursing staff can manage dietary. So, you know, the best thing you could do is send your dental card, your business to the oncology department. We are always, always looking for dentists. So drop off a pamphlet, drop off a brochure. I am here. I offer PBM. Any oncology center, especially radiation oncology, is going to appreciate that so incredibly much. So go to your radiation oncology centers in your area and say, hey, I'm a local dentist. I have photobiomodulation. I can help patients with oral mucositis. And not only that, we're often looking for dentists, you know, for teeth extractions. A lot of our head and neck cancer patients come to us and they haven't seen a dentist. So it's always good when we're always going through our cards. Okay, this one's close by. This one's close by. So reach out to your oncologist. I always say, come in and do a lecture for the residents. Hey, I'm a local dentist. You know, I'm willing to come in and do a dental lecture for your residents, because we send all of our head and neck cancer patients to you guys. We don't know what you do. It would be really great if you came in and did a lecture for us. Hey, when you send them to us, here's what we do. This fluoride treatments, and this is, you know, that's incredibly important. So get to know your oncologist, especially your radiation oncologist. Not one of them is going to say, go away. They're going to really appreciate you.
My question is, you said some insurances are covering for PBM, medical insurance wise.
Yes.
Which companies and specifically? And then
James had that in his slide. So Blue Cross Blue Shield, if you submitted it, with the data out there currently, I would imagine you would get reimbursement from any insurance company. Now, the problem is the amount of red tape that you might have to go through to get it. There's enough data out there, enough peer-reviewed literature. Blue Cross Blue Shield, I know, is very big, and they and they do. We don't have Medicare and Medicaid coverage yet. So that one would be, you wouldn't, because, most of those patients, there's no, appeal process. They either, if they're not a managed plan, they approve it or they don't. But if you have a Blue Cross or Blue Shield patient, you certainly would probably have no problem getting it reimbursed. What they reimburse it at, I'm not sure. And how much red tape it causes, I'm not sure. So in my university, we have not gone down that path yet. The big reason is because our billing department is so afraid that they'll be overwhelmed if it gets denied, which it will. What'll happen is you'll submit for, PBM for OM, and it'll get denied, and you'll have to do a peer-to-peer, or you'll have to send further information. And they're just worried that what will come on the back end is not, until they get a process in place, it's not worth it yet. So, we're getting there. And I think in 2 to 3 years, every insurance is going to approve it. It's no reason why they wouldn't. And like I said, if you really have the time and energy, you would definitely probably get reimbursed for it now. I couldn't say that 2 years ago, but I'm almost 100% certain that if you fought, you would get it reimbursed now.
Yeah, good information, because I know we've tried to submit for medical for PBM and it's been denied. So
Yeah,
we'll look further into that.
Yeah. It's legwork. It's, it's having the energy to keep fighting.
Well, fantastic. I don't see any, all I ought to see is kudos to you.
Aw, thank you.
A lot of people have congratulated you on all the stuff.
It's just nice to finally have something to help the patients, and it's wonderful. It's really changed our practice. It really has.
So everybody here needs to spread the word.
Yes, definitely.
All
Thanks,
right.
guys.
Well, thanks so
have a
much.
good morning, evening, afternoon.
Yes. Just to let everybody know, next week we'll have PBM to treat nerve damage by myself, and medically compromised patients. Mel Birchman will be speaking on that. He has firsthand knowledge treating with his wife. Also, to let everybody know, those who are interested in laser dentistry, ALD has Foundations, which is basically gives you online information about beginnings of laser dentistry. So you have 5 different sections that you could take and learning about laser dentistry. So go on laserdentistry.org and you'll find information about that. For my implant fellow colleagues into there, I don't know if I'm going to be trying to use the 3 minutes in each section for analgesia to place implants, but it's good to know that. All right, the code for the completion for Annette's section is K23, so make sure you write that down. Again, you're going to have an evaluation. It's going to be submitted to you after this course here, and so return that so you can get your CE. Again, thanks to everybody for attending our second session of PBM, and you could use the Map Dynamics platform to access the recordings. Next week's session, again, is with me and Dr. Birchman, and you can post any questions on the discussion tab for each section. Each of these answers for the questions will be posted on the discussion when the sessions are not live. And then again, we'll have everybody back here for the final session in October 28th. So with that said, make sure everybody has written down the different sections, and thanks everybody for attending, and good morning, good evening, good day, and hope to see you next week.